So welcome. I'm Marie Harvey. I'm the Associate Dean for Research in the College of Public Health and Human Sciences, and I'm delighted that you are joining this seminar today. I have to confess that I have a BA in European history so long ago, so I'm particularly eager to hear our speaker today. Sunil Khanna, who is the Robert and Sarah Rothschild Endowed Chair of Global Health, will be introducing our speaker today, and he will also be moderating the session. And Sunil will also talk a little bit about the format of the seminar and before he does his introduction. So please join me in welcoming Dr. Khanna.
Thank you, Marie, and welcome everyone to our Friday research seminar. We're so glad that you're able to join us and for a research presentation by Dr. Christopher McKnight Nichols. Dr. Nichols is an associate professor of history and director of OSU's Center for the Humanities. His talk today is entitled The 1918 Flu Pandemic, History and Lessons Learned. Dr. Nichols founded and leads OSU's Citizenship and Crisis Initiative. Dr. Nichols is an expert on the history of the US's relations to and with the world and political history. An Andrew Carnegie Fellow and Organization of American Historians Distinguished Lecturer, Dr. Nichols was honored as Oregon State University's Honors College Professor of the Year in 2014. Dr. Nichols is the author, co-author, and editor of 6 books, most notably Promise and Peril, America at the Dawn of a Golden Age, published by Harvard University Press. Just this month, Dr. Nichols published a co-authored article entitled Reconsidering the 1918-19 Influenza Pandemic in the Age of COVID-19. Dr. Nichols is a frequent commentator on air and in print on US foreign policy and politics, and is a permanent member of the Council for Foreign Relations. So without further ado, please join me in welcoming Dr. Christopher Nichols.
Thank you so much for that kind introduction, Dr. Khanna, and thanks so much, Dr. Harvey as well, and the whole team here in the college for inviting me and setting this up. It's wonderful to be with you, talking about such a relevant piece of history as the 1918 influenza pandemic, to talk through some of the lessons learned from that moment and give you a broader sense of what happened in that era. First, I always start with one acknowledgement, at least, beyond some generous thank yous to my colleagues and friends, which is to say, I'm a historian, I'm a scholar of this era and this topic, but I'm not an MD or an epidemiologist. And also, there's some fantastic work published on this topic, and I'm relying on and standing on the shoulders of giants in some ways in making some of the arguments that I will be here today. And so at the end of my presentation, I'll have some references, and feel free to be in touch with me if you'd like to learn more about different areas of scholarship related to, say, the public health or non-pharmaceutical interventions related to the pandemic of 1918 and 19, or questions of history, social history, and other topics. So I will share my screen with you so you can see some slides. There are some fantastic images from 1918 and 19. What we'll do today is first, I'll start with the present, give you a little sense of what's going on right now. I imagine a lot of you know quite well what's happening and been following the news of the virus closely, of COVID. Use that present moment to illuminate some patterns and trends from the past. Then second, I'll tell you a little bit about the 1918 pandemic itself. We'll focus on the US and the global contours of the spread of the virus around the world, what some of the measures were taken in terms of public health, public policy, and the wartime context of World War I, which is essential for understanding what happened. And then third, I'll try to telescope in and out as we do this to think about successful and unsuccessful public health efforts, or what even constitutes success, given the limited techniques that were at the disposal of those working at the time and the knowledge base. And also think together a bit more about outcomes, lessons learned, and key parallels between 1918, 19, and the present. So first off, let's start with the present. Let's think a little bit about what's going on now. Public health response effectiveness, as you all know, probably as well as I do, it matters a lot in international relations. It matters a lot in terms of prestige and respect in the international community. One of the things that we've learned throughout what's gone on in 2020 related to COVID is that the US's response to the outbreak has not been positively viewed by the world community. That may be a diplomatic way of saying what's actually happened here. And so if you look to here, the Pew Research Center's recent findings last month in its polling, the majority of the world think the US has responded badly or very badly. Now, one reason that I want to point this out isn't just that world opinion is diminished here, but that public health responses are also very important in terms of international relations broadly construed. When a nation doesn't deal well with outbreaks within its borders or other kinds of crises and challenges within its borders, say protests, reform measures, and other issues, that has ramifications for international relations more broadly. The US's leadership in the world, which is transformed fundamentally under the Trump administration, is cast in more doubt because of its response. Now, there's a real distinction here that we should make between 1918 and the present. Expectations of public health in 1918 and a federal response were much lower. And so the Wilson administration, in fact, did not deal much with the pandemic from the first wave, which comes in the spring of 1918, through the second wave, and was very slow to get involved in that second wave, the deadliest part of the pandemic. Citizens didn't think a lot about the obligations of the federal government to take care of them when illnesses were spreading through the community. And this has changed a tremendous amount. It may be the most important, salient difference in public health and public policy over the last 101 years. The expectation now is that, especially in top democratic countries, rich nations around the world, that citizens will be helped by their federal government significantly. And we can talk more about that in Q&A, but this is a very important distinction to start out with as we think about the current response of the US and its relationship to the world. Here's another way to tackle this, right? Poor marks for America's response to the coronavirus. The counterfactual here is that this would not have been likely or possible in the World War I era. First, the main concerns for the Woodrow Wilson administration were war-related. In fact, and this is really striking and it's worth noting up front, Woodrow Wilson never once gave a speech on the influenza pandemic that killed 0.6% of the American population, 675,000 Americans. Never once gave a major speech or issued an address on the subject. His sole singular focus was on the war and peacemaking. You can't imagine that happening today, whatever you think of the US president's response or leaders of any country's response. This is a really important contrast to draw out about our expectations and about the way leadership functions. So too, the economic questions related to the pandemic, quickly looking at the present and thinking about the past. You see here in the middle, we find the US here in the second quarter decline of the economy. There was a downturn in the 1918-19 period. People were out of work, schools were closed, businesses were closed, limited numbers of people were allowed into essential businesses in the fall of 1918. But what economists have shown is that the economy came roaring back relatively fast after the war, after the pandemic. And that though there were cyclic downturns in the 1920s, it wasn't all a roaring 1920s of affluence, as is sometimes characterized. The American economy did bounce back. And so the concerns about the economy that we've heard in recent year, in the last year, for instance, and the false binary that we've heard that pits, say, health versus the economy, and I would emphasize that is a false trade-off, that you can do some of both, were not the kinds of questions or concerns you fundamentally heard in the political debates of 1918, not least because the federal government in 1918 didn't issue major guidelines until early October of that year. And again, remembering, and I'll talk you through this, the first wave of the influenza came in March of that year. So that's an important other point of comparison. Thinking about the US's actions this in 2020 and in the COVID crisis compared to other nations, this is also why people around the world look at the US and think that the US has not done particularly well. Here's differences in January to July employment rates, right? So if you think about the US's kind of belief in a sort of rugged individualism, that businesses and individuals need to take ownership of their own lives and not have a more robust social safety net, for instance, this is a stark contrast and much more like 1918 than for the other 25 richest OECD countries in the world today. So we're in an odd sort of way, the continuity here that I'm describing up front is that the US has continued to put the burden of dealing with the virus on individuals. And very similarly, the Wilson administration permitted cities and states to be the leading actors in dealing with the virus as it spread across the country. So most of the action then, like now, came through innovation by mayors and governors and public health officials at the local level. And most of the suffering fell on individuals and was not supported by state structures. So this is an interesting way to think about the difference then and similarity between the two. Here's another way to look at that. Difference in virus outcomes between the US and other wealthy OECD countries. Here we see sort of new deaths and new cases, right? The US has had this disproportionate number of per capita deaths in comparison to comparable countries. I'll show you some more slides to think about this in comparison between 1918 and 19 and the present. But the US also had more suffering per capita than many comparable countries then. Here's just to give us a little update, a snapshot of the present as of October 9th data, looking at the US's relative response or anemic response in the world community. And similarly, just looking at the US and cases, as opposed to what we'll talk about later, the techniques for flattening the curve that were known in 1918 and 19, the techniques for closure policies, hand hygiene, things like mask wearing that were known and deployed. The US in 2020 should have been far better equipped to do and enact those kinds of measures. You could argue that the US did better in 1918 with the measures that it had at hand and with a much more rudimentary health infrastructure than the US has done today. Now we'd have to decide by which variables we want to make that case, because more people died in the US then per 100,000, and there are a host of other ways that the suffering was far worse then, not least because that virus was most infectious to the healthiest people in society. We'll talk about that in a moment. So here's this comparison just to start us out thinking 1918-19 versus 2020. The thing that stands out to me, stands out to historians of this when we've done panels and talked to wider publics, is that we never expected the US would have death rates and beginning to compare to 1918 and 19. Even so, when you look at this, the US certainly has suffered far less than that devastating influenza of 1918-19. But when you look at this across the board, you get a sense here of deaths, 10 times more deaths per 100,000. Or in 1918-19, a much higher percentage of the population that died. But when you look at the scope of what happened in that period, it is quite illuminating to think about this. And it's useful for us to sort of set the stage by thinking about this moment. I think in public health, it's very important to try to move beyond just the raw data. Historians certainly also want to do that. So I wanted to start out. So you had some of this comparative information. 50 million people dying around the world is a best estimate. Historians range in their estimates from roughly 20 on the low end to 100 on the high end of 1918-19 deaths. In comparison, in the world, we're looking at about 1 million. We just surpassed that number 2 weeks ago. In the US, we just hit 213,000 dying in the US. That's roughly the number, very close to the number, who died just in the deadly fall wave of the influenza in 1918, in just something like 8 to 10 weeks in fall 1918. So another way to look at it, this is a little bit more outmoded, but it's really striking. It certainly strikes me when you look at why, say, the world community in those early images might not, in the Pew polling, why the world community might not think the U.S. has done very well in its response. I think this pretty well encapsulates it. That as a percentage, world deaths, the US was around 1.4% of the influenza, but is sitting here at over 1/5 of world deaths in 2020. And that in and of itself seems to constitute a botched response given the US's percentage of world population. The thing that I want to point out here as we start thinking about similarities and differences, in 1918, the overwhelming majority of people who died from influenza were in roughly the 18 to 45 range. Some argue a little bit older than that. 1/2 to 2/3 of those who died were in that age range. Epidemiologists speculate that that's because the older generation had been exposed to something approximating the H1N1 that came on the scene and was so deadly in this era. It's a marked contrast to what we've seen lately, that people with comorbidities and the older age demographics are the ones by far the most likely to die. We don't yet know what the longitudinal effects, of course, will be of COVID. There certainly were longitudinal effects of the influenza. We were talking about this just before the talk began. If you look at the literature of the 1920s, for instance, you find subtle references to the flu all over the place. It used to be said that this was a forgotten flu, a forgotten pandemic. This is the famous words of Alfred Crosby, a historian, an early, very influential historian of the subject. But when you look to the literature, when you look to the popular culture of the 20s, you find lots of references to the deeper effects, not just the deaths, but the ways in which people, say, had to stop on each floor walk up home because they couldn't breathe very well, or people who no longer ran to do things, others who had circulation problems that were attributed to this as well, and general issues related to heart damage were well known amongst doctors in the 20s as they tried to analyze what other systems might have been affected by the virus during the 1918-19 pandemic, including people who didn't show many symptoms. And those are the kinds of questions and analysis we'll be doing for maybe another decade. So, all right, let's turn to the history. Let's think about this in more specific, in more fine-grained detail. One of the things that I always emphasize when I do talks about the 1918-19 pandemic, my recent article emphasizes this, is that we need to think about the suffering, the individual suffering. I just gave you a lot of abstract numbers. They're stark. They tell part of the story. But the essential story of 1918-19 is of massive widespread suffering, of fear, and of related inaction or being slow to take action based on what was happening in that moment. I'm drawing a bit on my colleague Nancy Bristow from the University of Puget Sound, who has a brilliant book called American Pandemic, about the kind of lost worlds of the pandemic. And here you'll see up top, Victor Vaughan. This is a quote from A Doctor's Memories. Vaughan was the founding editor of the Journal of the Laboratory of Clinical Medicine, served as a colonel in the Army where he led its division of communicable diseases. He'd seen all kinds of communicable diseases. He was an expert on that. When he gets over to the East Coast, to Fort Devens near Boston, where troops are coming back across the Atlantic with the more deadly, as part of the second more deadly wave of influenza. When he gets there in the fall of 1918, he's shocked by what he sees. This is unlike the other communicable diseases he's encountered. And here's the quote, right? They're placed on the cots until every bed is full, and yet others crowd in. The faces soon wear a bluish cast. A distressing cough brings up the bloodstained sputum. In the morning, the dead bodies are stacked about the morgue like cordwood. It really shocked some of the leading medical professionals in the US how rapidly the flu was killing the healthiest, strongest people in society. And this had secondary effects throughout the US and around the world, because troops mustering for the war were giving this to each other. They were healthy, they were ready to go. They were, in their communities and their families, seen as the strongest, most capable people, and they were being struck down, literally dying in the streets, lying within 24 hours of coming down with symptoms. Here's another quote. When the chest was opened up and the blue swollen lungs were removed and opened, Dr. Welch saw the wet foamy surfaces with real consolidation. He turned and said, "This must be some new kind of infection or plague." And he was quite excited and obviously very nervous. And this is from an aide. It was not surprising that the rest of us were disturbed, but it shocked me to find that the situation, momentarily at least, was too much for even Dr. Welch. So you have these scientists coming in to do research on the disease, to figure out what's going on. When they see the suffering, even they who are there prepared for this are taken aback. And I think that's really important to grapple with. And, Vaughan actually admitted that he remained haunted by his experiences of this. He was the dean of the University of Michigan's medical school, a guy who'd seen all kinds of death and disaster. He was haunted by it. He was so impacted on a personal level by his experiences of 1918 that he acknowledged, that it really changed his sense of himself as a medical professional. He wrote, "The saddest part of my life was when I witnessed the hundreds of deaths of soldiers in the army camps, and I did not know what to do. There was nothing I could do." That's kind of the heart-wrenching kind of account that I want us to take account of, because most Americans who suffered from influenza got no medical care at all, or next to none. And so these are people in army facilities being treated by some of the best doctors in the country, and the doctors are at a loss. So how did it begin? What happened? What's the spread, right? Well, I could talk you through this for hours. As you can tell, it's fascinating history. I want to keep it concise. There's a lot of debate over where the influenza began. There are theories that cite some of the Western Front in France in 1916 and 1917. There's a China origin and a Vietnam origin that are documented. Most historians subscribe to a consensus view that the really virulent form of the flu, as we can watch it be transmitted around the globe in 1918, came out of Kansas. The origins of the bug itself, the virus, may have been somewhere else, but somehow it got worse. And we see this at Camp Funston, Kansas. We see this coming out of a place called Haskell County in Kansas. This is in John Barry's book on the influenza pandemic. And suddenly, something like 24 of the 36 largest U.S. Army facilities are overwhelmed by cases, as I note here, right, from John Barry, that a soldier recalled that of the 12 men who slept in my squad room, 7 were ill at one time. That's a pretty common kind of a number for this first wave. Well, how do we know this? Well, we've heard since this began, since we first started talking about the subject in February and March 2020, that some people have said that there wasn't that much data to understand past pandemics, or to think about the flow and of virus across borders, how it might be stopped, and that sort of thing. And historians and public health scholars, I don't need to tell you all, were shocked to hear this, because we have a lot of data on it. In fact, the medical records of the nations at war in World War I provide ample evidence of who got it, when, how long they suffered, how long they were hospitalized, when they were released back to their units, or if they ever were, when they died. Census records then can amplify this. And this was very important for the war effort. Until the war ended on November 11th, the militaries engaged in the war, which was a global war, the first sort of truly global war in a modern sense. Provide a massive amount of data, because these are modern bureaucracies that were waging the conflict through sending material, troops, human beings, ideas, viruses around the world. So we can watch, actually, as the virus moves globally, and we can also watch as people don't take precautions, even when they know the flu is out there. This is well into the second wave. Here's wartime workers in the US at the munitions building in Washington, D.C. There you can see the Washington Monument in the past. They're being served hot chocolate. This is when people were beginning to wear masks in the US. And look what they're doing. I mean, it looks like a super spreader event. It looks like what we saw that created the hotspot at the White House just a few weeks ago. These kinds of activities continued even in the face of the beginnings of public health knowledge about not doing this sort of thing, about social distancing, hand hygiene, not sharing things. You can see a few people there do appear to be trying to cover their faces. But the spread of the virus went around the world within a short few months. It went from Kansas in March 1918 to all the way to Algeria by June. You had it in New Zealand in July. Australia set up more strict quarantine measures, but by 1919, even Australia had it. So, and islands and other communities that were able to try to hold it out longer, nevertheless, virtually all succumbed if they had sizable enough populations and engagement with the world economic community. So the Great War is the essential context for this. I'll talk you through it really fast. Feel free to ask questions if you want. One of the reasons why public health responses globally were so bad was because of the war. And particularly, you saw troops like these here on the upper left, American troops in Syracuse, New York, mustering, getting ready to go across and get to the front. Here you see French forces near the Western Front. These are the prime conditions, I don't need to tell you all, for incubating and spreading viruses. You have all these young men together in closed space, coughing and spitting on each other, and then traveling together. You also have the kind of masculine and militarized context where people try to ignore symptoms to stay combat ready. And you have military infrastructures that also want to minimize the risks of the spread of viruses and flu because, of course, they need to stay engaged with the war. You also have a kind of hyper-patriotic element involved, and this is something I think is really useful to consider today and in terms of public health responses. How can you muster nationalism? How can you use patriotic language for the good of the people? How to think about collective or communal good. One of the things we see in the World War I period was this concept of the so-called draft slacker, people in the US, people in the UK who didn't step up to join and enlist and were drafted to the war. If they didn't show up when drafted, they were called draft slackers. And there was a whole committee on public information headed by a muckraking journalist named George Creel, who spun out arguments and propaganda related to this, saying you have to do your national duty, your patriotic duty. Well, when the pandemic hit, the Red Cross and other institutions in American society leveraged the exact same kind of patriotic language. And you see this in the press, actually late 1918 and 1919, in the concept of a mask slacker. The mask slackers were people who weren't abiding by ordinances, voluntary or required, or not required, required or not, to wear masks. And so here you see, if I fail, he dies, this kind of ethos of Red Cross folks, women, volunteers making masks. So too, their efforts to help the war effort in various forms were cast in this kind of patriotic or martial language, this militarized language, fighting the virus, fighting the enemy. Now, the problem of that, of course, which we'll get to shortly, is that there are countervailing forces involved, right? So the nation states involved in the war did not want information about the virus getting out. The troops were not able to muster, not able to fight in the conflict was an enormous problem. And so in the British system, something called the Defense of the Realm Act was passed in 1914. It prohibited communication that would undermine the war effort. A very similar thing happened in the US in 1917 and 1918, espionage and sedition bills. These were actions that then prevented the press and other people from talking explicitly about anything that would undermine the war effort. Most famously in the US, the socialist five-time candidate for president, Eugene Debs, was jailed for speaking out against the war under the conditions of the Sedition Act. But the key piece of this to think about the virus is that it prevented the press from covering more accurately what I just described, for instance, 24 of 36 major army bases having their medical wards full of a new virus, of people suffering from a new virus. Here's the sort of World War I propaganda that would be a piece of this puzzle, right? Don't talk. The web is spun for you with invisible threads. Keep out of it, help to destroy it. Stop, think, ask yourself, right? So don't talk about the virus, especially minimize the virus. And you see this impacting public health officials who, out of patriotic measures and out of this kind of perhaps worry about the legislation involved, minimize the risk, even up through fall 1918, even attempting to have mass events when they knew that probably wasn't wise, or other experts were cautioning against those efforts. Another piece of this puzzle was another form of minimization. We heard some of this early on in COVID. The so-called Spanish flu was also known as the 3-day fever. Or it was a new name for an old familiar disease. The last of the epidemics that had hit the US was 1889-90. The grip a kind of a flu. Hey, don't worry about it. This won't be very deadly. You can get over this pretty rapidly. This kind of information came from the Surgeon General, came from the Red Cross, came from some of the most trusted parts of the US public health service, such as it existed then. And it was a much weaker and less capable body in this period. So this minimization of the flu and the possible outcomes was part and parcel to the US response, both part of the ways in which war information was restricted, and also the way in which a wartime environment really generated a public health response that was somewhat less about public health and more about rallying around the flag. So why the Spanish flu? This is another permutation of the same militarization, martial language element at work here in the wartime context. In very brief, as many of you I hope know, Spain was a neutral nation in World War I. Now, the main difference that made was that their press wasn't censored in the same way as the British, American, French, German, Russian was. So in this context, when the Spanish king, Alfonso XIII, came down with a bad case of influenza in May 1918, and a number of other members of the cabinet and the aristocracy and prominent members of society got cases of the flu, the Spanish press covered it. The Anglo-American press then picked that up, particularly the British, and they called out the Spanish as having an inferior climate and hygiene that was conducive to the spread of the virus. So this wound up being a kind of racist or racialized, politicized move. The British and the Americans thought that the Spanish were sympathizing with the Austro-Hungarians and the Habsburg Empire because they had direct familial genealogical connections to the Habsburgs. Now, of course, pretty much all the royalty in Europe did. But in any case, there was this sense that the Spanish were sympathizing with the enemy. And so it became the Spanish flu, that it was covered, that it came out of there, that they were more inferior, more susceptible. The irony of this is that the Spanish called it the French flu because they blame French war workers coming through Spain. The Germans call it the Russian pest. They blame the Russians. The Russians blame alternately the Germans and the Chinese. And so there's a lot of this martialization, militarization, and weaponization of the flu that we've seen as well in the last year, right? This so-called, Donald Trump calling it the Wuhan virus or China virus, when of course viruses know no borders. Viruses know no nation state. And so, again, this is mapping on pretty neatly the 1918 to 2020 moment. All right, I want to keep us moving. It's a fascinating story. Second wave of influenza. So in the first wave was not as deadly. So if you're looking at the Western Front, if you're looking at troops getting it, for instance, in the British Navy, 10,000 sailors got sick in May and June, but only 4 died. If you're looking at the French outposts, the vast majority of French outposts had reported very few deaths. But at least one French army post in midsummer, of 1,000 soldiers there, 688 were hospitalized and 49 died. So that's 5%. By the end of the summer, late August into September, you can look at the documents that were coming secretly back from British naval intelligence and American intelligence officers, particularly out of Northern Europe. What they see alarms them dramatically. They raised the red flag. One report from US naval intelligence officer reported, stamped secret and confidential. When he looked at Switzerland, he said, the disease now epidemic throughout Switzerland is what is commonly known as the Black Plague or the Spanish flu. And he worried that it had resurfaced in so virulent a form that it would undermine the war effort. That the virus was now not that 3-day fever that was putting people up out of combat effectiveness, but then they could come back from, but rather was something far worse. And when they looked at Switzerland, they saw a health infrastructure that they thought was comparable to their own. So unlike this pejorative way that the Spanish were thought of, the Swiss were thought of as being more capable. And so this second wave travels back across the Atlantic, and you can see this in the documents of the US military, and it hits the US coastal port facilities, major cities, traveling with the Navy, traveling with soldiers coming back. And the story of this is dramatic and horrific. Public health officials know that there's cases are rising in cities like Philadelphia and Boston. Remember, I started with that Boston case where the bodies are stacking up like cordwood. Army doctors are astonished and unable to do much for their patients. Yet in the city of Philadelphia in end of September 1918, with cases rising in the port facilities, they hold the largest parade ever in the city of Philadelphia to support the war effort and to sell Liberty Loan bonds. At that point, you saw 2 days after the parade, the head of public health there conceded that, quote, the epidemic now present in the civilian population was assuming the type found in the army camps. But he still cautioned, don't be panic-stricken over exaggerated reports. He minimized. Same with the U.S. Surgeon General, Rupert Blue, who said very similar things. A number of the reports then said nursing was halting the epidemic. Modern scientific nursing was halting the epidemic. But as I don't need to tell any of you, this large super spreader event could not be stopped, could not be placated by optimistic words. So across what was happening there in Philadelphia on its worst day, 759 people died in one day. You had the Philadelphia hospitals filling up. They had to build supplemental hospitals. They also all filled up. You were looking at numbers of deaths that went from 1,000 to 2,000 to 5,000 within just a month, in that city. And some of the most horrific social historical accounts are of clergymen driving carriages to pick up the bodies, and they simply did not have the capacity. And so you had bodies lining up on the street, not even in hospital wards at this point. And that's precisely what people who were raising the alarms in March and April in the US were worried about. If the curve couldn't be flattened with a virus that we didn't have new treatments for, it would look or could look very much like that in cities like New York. And as we saw, at a few moments there, early on in COVID, it looked like it could get that bad in the city of New York. As you look around, then the responses, we look around the urban responses to the pandemic. Here's a characteristic example. This is from a Library of Congress. In some families, there are none left to care of burying the dead, and others are unable to bury them or cannot get undertakers. It was pretty common to see the most healthy people in a family, the people in the childbearing age, of the prime workers in families, for instance, dropping dead rapidly, right? And so because it affected so many of the youngest and healthiest people, and one of the theories about that is this so-called cytosine storm, that people's own immune systems, really healthy people's immune systems, were overwhelming them, and they were drowning effectively in their own immune responses. So this was characteristic. And one of the things that historians emphasize about this moment, again, without good federal or state or local leadership, people get really fearful. They're not getting strong messaging early in the fall of 1918. They're starting to see this wave of death, particularly in the US East Coast. And so as this plays out over more time, and I'll talk just a little bit more about that as we go, you see less willingness by people to volunteer to help their friends, to help their community members. So one messaging lesson from this moment is to have clear, honest, rapid communication with the wider public, even if it's bad news. Because no news or minimizing can lead to more chaos and can then therefore have secondary effects. And in the US, that meant that a lot of Americans remained unclear about how the virus was spread all the way up through into early 1919. Here's an example, halt the epidemic, stop spitting. But at this point, already there were some places thinking about masks and pushing more for social distancing. A real continuity we see between then and now that's worth noting is that you had pushback from a number of sources, even well-meaning sources to some extent. So here we see, I've excerpted the Philadelphia Inquirer writing that the strict closure orders that suddenly came down, the lockdowns that came after that super spreader Liberty Loan parade went too far, that they made the case, the editors of the Philadelphia Inquirer, for instance, made the case that shutting down schools, churches, theaters, largely just, promoted unreasonable fear. And they said, go back to regular life, with precautions, but not with closures. You saw, other medical professionals, for instance, saying the public should be educated to the fact that the disease is not as deadly as many believe, even when they had evidence, arguably ample evidence, that it was that deadly. So again, this is the sort of thing we've seen in the US, the kind of battles between experts and individuals in public, although there's been a lot less of that, arguably, in 2020. People often ask me about what happened with the economy, and one of the lessons that historians learned from 1918 and 19, and I presaged this earlier, is that there's no such thing as business as usual in a pandemic. So, here's the Wall Street Journal, approximately 50%, and almost everywhere you've seen decreases in production. I'm just paraphrasing. Loss of trade, which retail merchants throughout the country have met with, has been large. And I have some slides, if we want to get to them later, about some of these estimates. But the point is that people vote with their feet. They don't have to be sick, for instance, to want to minimize risks and spread, and therefore not show up for work, including, this is before the end of the war, inessential war industries. And you had war industries reporting at times 40, 50, even 60% of their workforce not showing up. That's the kind of thing that happens in a pandemic. And we've seen some of that already. There are other examples here. I thought I'd just add one, between a soldier abroad and his sister at home. The sister goes to work. There's so many accounts like this. She goes to work, she volunteers, nursing, she contracts the disease and dies very rapidly. This is sent from the father of both of these kids to his son out on the front. And what's interesting here, and again, I want to point this out because it gets at this patriotic language and how to think about fighting a virus, is that if you see the third paragraph down, here he is and telling his son that his sister's died. It remained for your sister and my more than daughter to bring the first golden star to our family banner. And she did it like the soldier she was. So the home front war against the virus here is literally being described by the father as that, right? A golden star, war work, war service by the nurses at home. Here's an example of those folks, Red Cross Motor Corps. A key element of this was that so many of US medical professionals were men, and many of them were in the Army. And so you wound up having more care being done by women in this moment, more volunteer service by healthy women. And this had secondary effects in terms of keeping women out of the home. And when they went down with sickness and men were often abroad fighting or mustered for other war industries, you wind up having more suffering from kids. And the social history of children of people afflicted by the viruses in this moment is really searing as well. Kids just out wandering, schools are closed, really deep tragic circumstances, children being hit by trains, going off in various ways, not staying, they weren't comfortable having the kids stay with parents or other family members. And there's a wide array of ramifications of this that I don't need to elaborate, I'm sure you can imagine. So here's a little bit on the spread across the country. You have the waves, it's a little bit worse on the East Coast. There are several hypotheses about this, that is in terms of case fatality rate, so far as we can estimate. And you can watch it move across the country so that the West Coast is hit later, obviously, than the East Coast. The first flu cases break out in the city of Portland here in Oregon in October. We can track it to the individual. He comes from Washington State. He travels to Portland on his way to Texas for training. He can't get to Texas for training because his flu case is so bad he's hospitalized. Lots of people he met get the flu from him, and suddenly we see an outbreak in the city of Portland. I'm happy to go through this more, but I want to get us to some Q&A, and I wanted to hit on some non-pharmaceutical interventions as well. So one of the things that we know, historians know, medical scholars have looked at quite extensively is non-pharmaceutical interventions and the conflict. Here I have the cover of the Philly Inquirer after that parade, right? Not talking much, if anything, about the rising cases of influenza there. And then you see another example, scientific nursing halting the epidemic and death now on a decreasing scale. Cases average only 1,875 daily. That's pretty horrendous number, and yet they're saying that with a positive sense. But as you see in that next subheadline, officials say entire situation is well in hand, nurses still needed. right? And so nurses' sole need. As I said, there's a nursing shortage and shortages of medical aid. So one of the things we know really definitively from the data in 1918-19 is that some cities that enacted closure measures, closing schools, closing businesses, enacting social distancing, fared best. The city of St. Louis is the best example. Their public health, lead public health official, and in that city there was only one, unlike some cities that had arguably too many chefs in the public health kitchen, only one. He was the son of a union medical officer who was kind of obsessed with infectious diseases. And he worked closely with the mayor of St. Louis to enact social distancing and quickly put on a number of other measures to close down the city. You can contrast that directly with Philadelphia that had that big super spreader event. And you see clearly that the city of St. Louis did suffer, and there was a longer duration to the viral outbreak there. They had nowhere near the overwhelming set of deaths and disaster that a city like Philadelphia did. So one of the lessons of this moment is that when you see an outbreak happening, you slam the door shut. That's the imagery that is generally described. Here's just another way of looking at the same thing. You know, St. Louis responding well, Philadelphia responding poorly, and the number of deaths there. But let's look at a couple other cities. You know, New York is quite comparable to Philadelphia. Pittsburgh is similar. Pittsburgh also demonstrates another lesson from that moment. That lesson is that because of the power of parochial schools, the Catholic Church, they have a slightly more layered closure. And one thing you can see here is that even as they close, they continue to go up. There's the peak still rises, and that's because they don't slam the door shut. They first close public schools, then close parochial schools, and so that lesson is confirmed with the example of Pittsburgh here. And then what happened in Denver? Denver's an interesting case. So this is what we've been thinking a lot about summer and fall 2020. What happened in Denver is that there was a group, we call them the amusement lobby, a number of people in different industries who wanted to reopen restaurants and theaters and billiards halls. They're persuasive enough as they see disease data going down to start to reopen the city. November 11th was Armistice Day, and even though it wasn't permitted, people ran out into the streets and partied for the end of the war. The combination of those two things, a premature reopening based more on sentiment and market logic rather than the data, and then the happenstance at the end of the war, led to an uptick, a significant uptick, a much higher second peak of deaths per 100,000 in the city. And so the lesson we tend to take there is beware premature closures, and closures should follow not the market, not sentiment, perhaps even at the expense of unemployment and some other issues, so that data and disease lead that process. And you can see this in lots of other cities. There's a great Journal of the American Medical Academy article on this that I have a link to and I can share with you all. Similarly, you can watch this in other graphs and charts, and there's a lot of ways to understand this. I want to get to some Q&A and talk a bit more with Dr. Khanna, Dr. Harvey, and you all, but I'd be remiss not to leap through a little bit more. Here's some tables that come right out of this, thinking about the waves and what gets worse, cities that suffer worse as they go, and that excess mortality is arguably the best way to understand the deaths of this time. You all probably have a good sense of this, but that is the deaths that are above those that would be expected for the city or state in the time frame in the recent past. And so one of the things that we look at here is what those measures have done to tamp that down. And a lot of comparable things happened in this era. There were open air religious ceremonies. There were exemptions for religion because of on First Amendment grounds in the US that led to spread. There were efforts to institute ordinances like mask wearing, particularly through public officials and people who could be mandated to do it for their jobs. You see on the left there, someone not wearing a mask, not being allowed onto public transport. You saw open air court cases, especially on the West Coast. Now, obviously, they're very close together, but the thinking was that at least they were outside, not holding those things indoors. You saw this with with barbers doing this, some masked, some socially distanced. You also saw bad information and incoherent information. So here, one of my favorites is the flu travels through the mouthpiece of the telephone, so quit talking so much. Or another here, right, continuous smoking ought to forestall the flu. And again, the Surgeon General continued to make the argument in March, through October 1919, there's no cause for alarm if precautions are observed. There you see troops gargling salt water. You see a purported vaccine being administered that had no effect. The sorts of things that happened were very much the same as today, with schools and churches and theaters closing. You saw the sort of incoherent messaging that got people confused, and should I avoid streets? Should I not go on the bus? Should I not get too tired? Don't take a taxi. Do take a taxi. Should I talk to people? A wide range of advice, some coming from things that, word of mouth, the sort of thing we would think of with Facebook or other social media, people doing their own research, so-called, to figure out what they should or shouldn't do. Building their own masks was another phenomenon of that era. Then there's a question of politics. The U.S. did vote. I could go into all this more. U.S. did vote in the election. There was much less turnout. There was a repudiation of Wilson and his party, the Democrats. The Republicans rise to power. And then at the end of the pandemic in 1920, Democrats are thrown out entirely. I could talk more about that. Some polling places closed. Most stayed open. One big difference was that the flu was not politicized. Neither party had a monopoly on it, and views on the flu weren't mapping onto whether or not people identified as Republican or Democratic. So the election did go on, and in fact, very similar to our current moment, Warren Harding in 1920, the Republican, ran for the presidency on a return to normalcy campaign of putting America first, of getting out of this moment of war and suffering and disease and getting back to some normal footing, some normal element. We also saw anti-masks. I know a lot of you probably know about this, so I won't belabor it, but if you want to talk about it, I'd be happy to. In San Francisco in particular, in early 1919, there was one large national organized group pushing against masks. They were it. You can look to their city and local city council ordinances and other efforts. The mayor San Francisco was sure masks were working well and did not heed their protests. That in fact, in San Francisco, there were mask protesters who were shot by police officers, and at one point, 100 mask protesters were jailed. Here's an example: mask slackers held on charge of disturbing the peace. This did not last very long, but in many states, you saw a few people who didn't abide by ordinances being cited, getting small fines, or going to jail. There was a widespread effort through December to keep educating. I like this cartoon here. Say ma, even the horses are wearing them. So hey, wear those masks or try. My friends in history circles and public health circles also talk about this. And I think I will leave it here with the economic and political effects of 1918 and 19. It seems clear that one impact was related to immigration restriction after 1919. That the U.S. passed the two most draconian immigration restriction acts in U.S. history. After that, this us versus them of the virus and the war translated to the peacetime. In 1919, there were a series of strikes and deadly race riots and racial violence that's related to the war and also to the pandemic, historians argue. You saw significant downturns in a number of parts of the economy and then an upturn into the 20s. So I will leave it at that for now. Thank you so much for having me with you, and I look forward to the conversation.
Thank you, Dr. Nichols. Thank you so much for a very interesting presentation, drawing some wonderful parallels between what happened in 1918 and what we are experiencing now. We have an interesting question from a member of the audience, and the question, I'll try to paraphrase this a little bit. So the question is, as you talk through some of the themes, racializing, minimizing, politicizing, I wonder if you had given this talk in the pre-COVID period, would you present the themes of your talk in the same way? In other words, are you watching history repeat itself in real time, and given your expertise in this area? And if so, what is your advice for public health researchers and practitioners?
There are several very good questions embedded in that. The first observation I have is that whenever I've taught the U.S. History Survey, which on a semester length goes from about the end of the Civil War, 1865, to the present, and here at Oregon State on a quarter basis starts around World War I. Whenever I've taught that, I've taught the flu and as a pandemic, as part of the World War I moment. And until this year, until 2020, students were not very interested in it. Maybe I didn't have enough public health students in my classes, but history students, others in required back core kinds of classes weren't that interested in it. But I could say definitively, I made these kinds of arguments talking about the racialized nationalization, weaponization of the virus in that moment, talking about the minimizing strategy and this lesson learned of rapid, honest communication from the federal government, and also what a lost promise of the moment was. So in 1919, Congress appropriates a little bit of money to study what was happening and what the techniques were. In the 20s, there's very little, formal thinking by politicians about how they might have reacted better. It almost all comes out of universities and other areas. So one lesson I would suggest for all of us, scholars and thinkers, is that we need to push this conversation, even now, about what's working, what's not, and predict or project how we should keep responding in the future. That is not just how we should respond to the second wave or if this virus mutates, but rather what can we continue to be studying in 5 years that will help us prepare for the next global pandemic? Because it's pretty clear, particularly in the US case in 1918 and 19, the US did no such thing. So for instance, Canada, after the epidemic in 1918, creates its first federal public health infrastructure. Coming out of this pandemic in the US, that doesn't happen. The US Public Health Service stays the same. It's virtually the same. And in fact, the federal government contracts in the 20s under the Republican governments, a small government kind of ethos. So I've taught it similarly and thought of the lessons learned might have been applied better. I mean, I think many of you probably are aware that there were several studies in 2019 and 2018 that suggested the US was as well prepared as any country in the world to deal with a pandemic. So what I take from that isn't that those experts were wrong, but was that this fundamental lessons learned about a federal response were right and they weren't applied. So for us in thinking about what we can do better, it's about messaging and being in contact with those folks, and then having a government that's responsive to these kinds of issues. It's amazing too, the CDC knows very well this history. In fact, if you go to their site right now, they've got a great explainer on the influenza epidemic of 1918 and 19. So those lessons are there for them to have learned and applied. That they've been applied unevenly is about political leadership, which is very much a lesson from World War I. Woodrow Wilson did not deal with this directly, to the great detriment of the nation.
Thank you very much for that response. I don't have any other question in the chat box, but I do have a question of my own for you to comment on. Now, you have very nicely drawn these parallels between the two pandemics. Excuse me. What would be unique from a historian's perspective about COVID-19?
Well, good. That pushes me in a good direction. Thank you. So the incubation period, I mean, there's a few things from an epidemiological and sort of timing perspective. The incubation period is different. The asymptomatic carriers are different. So with the flu, one piece that was interesting in 1918 was that the influenza basically wasn't a reportable disease as such. So part of the minimization that went on in cities like Portland, for instance, was to call it a heavy cold, or to say that the cases they were seeing might not be flu. They could be the cold, they could be the grip, they could be 3-day fever. And we've seen something similar recently. And I'm curious, I almost want to ask you all this question as well. One of the seemingly semantic but really important things about understanding viral epidemics is, how do we count who has it? How do we count casualties and deaths? So I mentioned, briefly, and I'm firmly convinced that excess mortality is a key way to understand deaths. But there is an urge at many levels to either undercount or perhaps overcount for different kinds of reasons. And so getting that clear and standard, at least within a nation, it seems very important to me. So we don't have battles like we've heard that become highly politicized about the politics of the numbers of deaths or disease. From a historian's perspective, what's different and is fascinating about COVID and tragic is that if the world was effectively globalized, as a number of historians, Eric Rauchway, Emily Rosenberg, and others have argued, if the world was effectively globalized as early as 1914 in the outbreak of World War I, the world is even more interconnected now, right? That's a basic truism. And yet the spread around the world is very comparable over 101 years. So why is that? The president of the U.S. Argues that his ban and work at the borders was useful, but a lot of other data suggests that it was not. That you can't keep viruses out of borders. So I think from my perspective, one historical element at work here is that with an even more globalized world, we need to have better measures than early 20th century techniques. The fact that we are using the same techniques, my whole talk is stuff that has been used in every country around the world in 2020. Those non-pharmaceutical interventions. We have no better, we now have some treatments, but the fundamental strategy at a public health and public policy level is very similar. Closures, right? Hand hygiene, social distancing, all that stuff. It seems to me that that it is all the more important to implement those policies more rapidly in a world this globalized. So for me, it stands out. It's as if we've amplified the global network such that diseases are going to move more rapidly, and yet our techniques are 20th century. So at the very least, the velocity of implementation of those techniques has to also increase.
Thank you. I know we are just about out of time, but I have two very, very interesting questions, and I wanted to ask you those. So
I'm happy to stick around. Love the topic.
Yeah. So one question is, when pandemics subside, do the pathogens go away completely? For the 1918 virus, were there even just a few cases in the following years, like the 20s, the 30s, or did it just disappear?
Yes, so very brief, very great question. So the H1N1, the cyclic seasonal flu that we now think of with its other variants, starts, most people argue, with 1920. So if you want to note that there was a fourth wave, the fourth wave would be the beginning of the cyclic flu that we now have, that we now live with every year, that comes out of China, or that comes out, that moves across the world and mutates after that. And so that we've lived with this sort of flu ever since. And in fact, the backbone of all the mutations of the flu that vaccines are made on is this one, is the 1918 flu.
Mm-hmm. And the final question that we have, which really hits at the core of what we are experiencing right now, that is the politicization of the mask. So the question is, did the anti-mask movement happen in Europe, outside the US, during the 1918, 1919?
Oh, love it. Yeah. So there's very little anti-mask behavior that's organized outside the U.S. Interestingly, one speculation by historians is that it's a kind of Anglo-American freedom of assembly, freedom of speech kind of critique. So I had in that slide, and I went over it pretty quickly, the two arguments that the anti-maskers make is, one, it contravenes my freedom of action, my autonomy. You can't constrain what I wear. And the second is that they're ineffective. And the combination of the two you see in Australia, in England, in the US, but that's about it. You don't find that in Germany. You don't find that in France. You don't find that in Russia and other places that did deploy masks in this period. And I would hasten to add, there was very little organized anti-mask behavior at all in this period. That martial language, the ordinances, they work in most places. At least people wear them. And frankly, also this virus moves more rapidly through the population. And so you don't have this. You don't have the sustained closure policies and the sustained mask behaviors that we have now. I mean, that we've been living with this since March, and really in the US never once flattened the curve enough to talk about another wave. We've had sort of a consistent plateau, is very different from the waves of influenza in 1918 and 1919.
Thank you so much. And once again, on behalf of everyone, I want to thank you for giving this very interesting presentation.
And I want to thank everybody who helped with the organizing of the presentation and also those who attended and also asked questions. So Dr. Nichols, thank you so much.
Thank you all. Thanks for having me. And if you want to be in touch for references or anything else, please be in touch.